Ladies and gentlemen, thank you for coming back to this last plenary of the day. However, an important plenary, because I think a plenary that really gets to the heart of what we have been discussing today. The importance of bringing together patients, professionals, and policymakers to drive transformation in health systems. I hope you enjoyed the case studies after lunch. Cancer, diabetes, mental health. But now, this afternoon, we will try to draw some of the generalizable lessons across these three case studies, because at the end of the day, it's not really about the thematic content, but it's about those horizontal lessons that we can draw from these case studies. But before introducing our panel, I would like to start by introducing the co-moderator for this last session, Marge Reinup. Marge has been a driving force behind the preparation of these three case studies. She works as a technical officer with us in the CPS division on translating evidence into policy supporting countries. But she's Estonian, and I'm sure many of you recall her in her former role as head of the country office here in Estonia. And for the past 12 months, Marge has actually been carrying a double burden, helping us prepare for this Tallinn conference over and above her normal work in WHO. And for this, of course, we are really grateful. Marge, over to you.
Thank you, Natasha, for your kind introduction. It's been really rewarding to go through all four sessions of Tallinn anniversary conferences, and in many respects, this is where I'm most thrilled about, because advocating for health systems that are person-centered is really one of the key points in Tallinn Charter, as well as in the 2018 edition of the series of conferences to support health systems that invest, include invest and innovate. But showing how co-creation between patients and health professionals have been driving the transformation agenda and can inspire this further has been really inspiring, especially working with these brilliant case studies. And because this is really what these case studies are showcasing here and being about. And I hope that you have been joining one of the sessions earlier. I also hope that you have seen the videos, and if not, then join us. As Natasha noted in the opening session, in planning the conference, we identified the need to rebuild trust between stakeholders as key to making our health systems more resilient and sustainable for the future. We therefore looked for good practice examples across the WHO European region. And the aim was to present 3 examples. We wanted obviously more, but only managed to fit 3. And to ask whether these cases provide inspirations and are scalable for your settings and to different conditions. As you all, unfortunately, had to pick one of the case study sessions to participate in, then the first session, what we really aim to is to provide a short summary of the case studies. And we start by showing you a video as a way of summarizing some of these points. But then, can we now show the video?
Люди, которые болеют диабетом, просто они немножко боятся, наверное. Вот есть такие люди старого поколения, наверное, они немножко боятся, наверное.
Ginekologi v Sloveniji so tisti, ki vzamejo bris materničnega vratu ženskam in zaupanje med žensko in ginekologi je zelo visoko.
Morda včasih kdo od njih želi kakšno dodatno razlago, ampak načeloma, če je izvajalec prepričan, da je to dobro za pacienta, kar počne, bo enostavno tudi v tej luči prepričal svojega pacienta, da je to dobro za njega.
Jeg tror, at før vi lærte en af os at kende, så var vi vidste ikke, hvad vi skulle sige til patienterne, når de kom ind. Og vi famlede os mere frem, og jeg tror, vi alle sammen, vi er sygeplejersker, og vi er læger, vi har faktisk lyst til at gøre det godt for de her mennesker.
Врачом я соглашаюсь. Я говорю, да, значит, если у меня сахар увеличен, значит, мне поднять надо дозу инсулина. А если доза инсулина поднята, значит, я себя буду нормально чувствовать. Если мне врач говорит, Мира, иди, надо вот так сделать, я соглашаюсь. Но мы сначала поговорим с ней, как всегда, мы как подруги. Я зайду, поговорю, посидим. Она мне объяснит, для чего, почему, как надо, например.
Вначале, когда мне рассказали суть проекта, что мы должны делать, да, во время проекта, я была под большим сомнением, а смогу ли я отдать своих пациентов семейным врачам, смогу ли я отдать своих пациентов семейным медсестрам.
I går kom der en ung kvinde til os, som jeg så har været læge for under tidligere forløb, og altid har følt, at jeg har behandlet et godt hjerte. Og da hun så i går kunne fortælle, hvor dårlig jeg egentlig er til at behandle selvskadende unge kvinder, så fik jeg en af de heftigste åbenbaringer i min karriere.
I hope this video served as a brilliant teaser for you who has not seen all the videos. But I'm also thrilled to introduce our first set of panelists who are the representatives of the case studies. And first, may I introduce Troels Flyholm Torp, an ambassador from the Danish One of Us. In Danish, it's En of Us. Initiative. And the next we have Natalia Dobrinina, chief endocrinologist from the Ministry of Health in Kyrgyzstan. And then Urška Ivanos, head of Slovenian National Cancer Screening Program, SORA. And it's great to have you here to provide your side of the story that we are presenting to you through these case studies. And if I may, Troels, may I ask you first to tell a bit about En of Us and One of Us and your role and the impact you feel that the initiative has had?
Yeah, certainly. The mission for One of Us is to close the bridge between insecurity in the somatic healthcare and those patients that have mental problems. And we do this to hold talks and speaks and have a dialogue with nurses and doctors where we, as an ambassador with lived experience, we are all someone who have had or have mental problems, but also have been a part of the somatic intensive care unit. So to close the gap between those two worlds, we have a very constructive dialogue with lived experience with doctors and nurses where we tell the positive sides and the negative sides of those experiences we have. And then we have a dialogue from it, and we have a very good feeling that these doctors and nurses actually want to learn and want to do it better. And one of the problems they often tell us is that they are very insecure about how to handle a patient that have mental problems. But as we tell them, this insecurity leads to saying nothing or doing nothing actually leads to more uncertainty for the patient. It's better to have a dialogue with the patient. And this feeling of closing this gap between the somatic and the mental health also have a side effect of being this ambassador for one of us, because to maybe inspire some of you out there who want to start something similar, just note that the feeling as an ambassador to be part of one of us is very helpful against self-stigma and stigma in general. So it's very much about taking a person with low self-esteem and a lot of self-stigma and kind of transforming them into be proud of themselves. And just to give an example, every time I put my One of Us t-shirt on to hold a lecture, I feel the same pride as a soccer player at a World Cup. Exactly the same pride.
Thank you so much, Charles, for this very honest and forthcoming reflection and telling for those who have not heard about the One of Us, to really be inspired and look for further. I really like the quote of one of the videos of when health workers, I believe it was a nurse, is that I think that all of us, nurses and doctors, we all mean well for these people. So there are well-intentioned, but they don't know the right ways of doing this. And Charles, as an ambassador, is bridging that gap and building that trust. So it's a really great initiative, and I was really touched by this myself, and I hope that this will be an example for others as well. So let me go now to Natalia, and your can you tell about the transformative case on diabetes care in Kyrgyzstan? I've had the privilege to moderate the session earlier and then know Natalia. So, but could you tell in brief words on what this story is about and what, despite its recent and short-lived project, so far it still promises a very successful and exemplary case for building trust in this health system. So please proceed.
My English is not good, and I will speak in Russian.
Yes, today we are speaking a lot about trust and transformation, and for Kyrgyzstan our project is trust and transformation of the system, the trust of patients to doctors and nurses, trust between doctors and nurses, and trust between Ministry of Health to patient and system. And all this attitude has changed within this project, within this 1 year and a half. I'm thankful to WHO and to World Diabetic Fund for choosing Kyrgyzstan for execution of this project. And I'm glad that our country was chosen to be shown on during the session and conference. And when the project began, it was very difficult for us because we were afraid to delegate our patients to family doctors and nurses, because we saw inpatient like not a supporter but the opponent at first, because those patient organizations work as opportunists, because they think that doctors should do something, but they are not with them. And our project showed that our patients can be part of treatment of diabetes and take some smaller interventions for the good of the patient. Our system is being transformed. Our nurses are becoming more confident because, like in many countries in Kyrgyzstan, we have lack of endocrinologists, we don't have family doctors in some of the regions, and our best system is our nurses. They are of great help. And now, after we have trained them, after they feel that they can do something to make some interventions to patients with diabetes, they became more confident. And when medical workers are more confident, then patients also have higher trust into them. And I hope that our project is not going to finish. It will be executed further. And this trust that we have achieved in many cases, these are first steps, and the steps are going to continue, that we are going to achieve big successes. Thank you.
Thank you, Natalia. And thank you also for trusting the patients and nurses and really building the trust between all the different stakeholders within the system. And as reflecting back to the video as you saw, and you were able now to meet also Mira, who was introduced in the opening session, who said, trust your health professional. So showing the virtuous cycle of trust and transformation and trust, building trust. So can I go now to Urška Ivanoš from Slovenia to tell about cervical cancer screening example?
Yes, thank you. So to put it a little bit in the context, cervical cancer is probably the most preventable cancer, and the WHO has set the goal of eliminating this cancer. And despite that, a lot of women in Europe are still getting this cancer and dying from this cancer, and more of half of these women are from Eastern European region. Mostly in the countries that did not manage yet to implement sustainable, quality-assured, organized screening programs. In the future, these differences in cervical cancer burden can be lower or bigger, also regarding the successful implementation and coverage of HPV vaccination. So where is Slovenia in this story? We have started with really high incidence in early 60s when our cancer registry was established. It's one of the oldest cancer registries in Europe, around 28 women per 100,000. And today we are down to around 6 women per 100,000. This is world standardized age incidence rate. And when we will fall below 4, then we will reach and hopefully sustain elimination of cervical cancer with continuous vaccination and HPV vaccination and screening and treatment of lesions. So what was the transformation in Slovenia that enabled the decrease of the incidence? We did have opportunistic cervical screening, which was not quality assured. Nobody knew how many women are screened. Nobody knew what is the quality. But the screening was done by the gynecologist for their registered women. And despite the cervical cancer incidence went down a bit with this screening, we observed in the cancer registry the increase of the incidence in the early 90s. It was observed in Slovenia, in some other Eastern European countries, but not in Nordic countries, which have already implemented all elements of organized screening. So the public health experts who were well connected abroad decided that it's time for change, to follow the evidence and switch from opportunistic to organized screening. And after that, it was done in 2003. After that, the cervical cancer incidence in Slovenia is going steadily down, and it's reaching record low levels. This change was not easy. And the trust from the screening providers and women was yet to be earned. Because what we have done when we switched to organized screening, we had actually kept the same screening test. We have prolonged the screening interval from 1 to 3 years. However, we had implemented the structure for getting women to screening, invitation system. We have reached the 70% coverage and above in 3 years. We have improved the quality of services. Screening is not just about benefits, it's also about harms. let's say the recall rate before the organized screening was 30% of women, every third woman had to be recalled after screening due to poor quality of smear or poor quality of cytology, or she really was at risk of the disease. Today, the recall rate is 5%, and we are detecting and treating more precancers and preventing more cancers than ever before. So when we proposed this new screening protocol, it was not easily accepted by the screening providers, which are gynecologists, because they didn't trust it is safe. However, we had a good, I would say, collaboration with Ministry of Health, with Public Health Department there, and it was a lot of struggle, but finally the legislation was there. All the screening pathway, including screening, diagnostic treatment, follow-up after treatment, was paid by the health insurance company. And when the screening was implemented, we monitored the results. And we saw that the results are good. And when the data came, and when the screening was going on for a few years, and I would say all the stakeholders saw that it is like inclusion program, that we are really including all the stakeholders, screening providers, laboratories, women, I would say politicians, and slowly I would say the trust was built that what we are doing is a good thing, that it is saving lives, it is protecting health, and that it is cost-effective. And if I may refer to the salutogenesis principles and the sense of coherence, in my opinion, what we did was we increased the sense of coherence within our screening providers and all the stakeholders, because we identified the barrier that stood in front of us and decrease of cervical cancer incidence. It was not evidence-based opportunistic screening. When we follow the evidence, when we follow the data, when we started to co-create the program together with all the stakeholders, and co-creating leads to ownership, and ownership leads to commitment and engagement and trust, and that leads to implementation success, then we saw the results. And the third element of sense of coherence is it worth it? I think that screening, I would say, health professionals, they want to do what's best for the patient. We gave them the tools, the data, the framework where they could improve their care for the patients. And they saw that this is beneficial for them, for the health of the women. And after the WHO Global Strategy for Elimination of Cervical Cancer came, that gave us the common vision. Yes, we can eliminate this cancer, and it will be probably the first cancer ever eliminated.
Thank you, Urška.
Three protagonists of these three case studies. And I think, to me, the most generalizable principle is that we see three instances of change and transformation. In Kyrgyzstan, there was this change. We heard the endocrinologist saying, could I really trust that my patients were going to be safe? Now we heard Urška saying that it was a change, and people were hesitant. The same with one of us, we heard the nurses saying we were fumbling our way through, and then, we were not certain. But of course, there's somebody who's going to give you a deeper dive, and he's actually the person who's responsible for all these videos, because about 6 months ago, he told me, Natasha, what about doing something really different and coming up with like 10-minute video documentaries? Let's do it the modern way. People don't read anything that WHO produces any longer. Let's do videos. And here, Martin, I would like to thank Jill and Alison and Jason and Gordon, because Jill and Alison actually work with Gordon. This was really an effort across the organization. And Rami, who took care of putting these videos together. We took a risk. We hope that you enjoyed them, that you will share them widely and continue to enjoy them. But now you know who was really responsible for pushing us to do this. Martin, the floor is yours.
Well, I'm certainly not responsible for all the work that was done by the others you've heard, but it is true that collectively we did come up with this idea. So, as you've heard, almost a year ago, a number of us met in Copenhagen to plan this conference. And we had one principle that took precedence over all of the others. And that is that the health system exists to serve the people that depend on it. Now, those of us who are involved in health policy, whether they're academics like myself who undertake and hopefully disseminate the research that we hope will inform the policy, or like so many of you in this room who must make often difficult decisions with limited resources, we all must do everything we can to ensure that the patient, along with the frontline health worker caring for them, is at the center of everything we do. Now, we talk about patient or person-centered care, but do we really mean it? We're all under huge pressure. We've got too little money, too little time, and too few resources. Often the last thing that we want to hear is that some group of patients or some health worker in some faraway clinic has had a bright idea and they want us to make it happen. We also have to accept that life is getting a lot more complicated. Now, once, most of what healthcare workers did was involved a simple one-on-one interaction. The patient went to the doctor or their nurse with an acute problem. They received treatment, or at least relief for their symptoms, and that was it. Now, there were some people living with lifelong conditions, like those with type 1 diabetes after the discovery of insulin in 1921, or hypertension after the early 1960s. But relatively few people lived long enough to accumulate the complex multimorbidity that we now see. And now, a patient with 3, 4, or more conditions will often require an entire team to meet their needs. And these teams are constantly changing. We're seeing new roles emerge, like specialist nurses, clinical pharmacists, and teams that provide the routine management of chronic conditions in some countries. In the country I live, if you have a chronic condition, you will very rarely see a doctor for your routine management. And patients are taking on much more responsibility. They can monitor their own physiological parameters with equipment bought from Amazon. There are other retailers as well. And in this situation, the task of the health policymaker is to ensure that the system makes it easy to get the right mix of people with the right skills and the right equipment in the right place at the right time to meet the needs of the patient. Yet far too often, we fail to do this. Now, often the reason is simple. We just don't ask the people who could help us to find the answers, the patients and the frontline providers. We come up with solutions on flip charts in a room in a ministry or a university and somehow think that this will work on the ground. Yet when we take the time to work with communities, we can get remarkable results. I know this from my own work with hypertension. As I said, we've been able to treat this condition safely and effectively for decades, and yet in all of our countries we do it very badly. So I and my colleagues in the PURE study, a study run out of Canada where I lead on the health systems bit, we spent a year developing a package of care for disadvantaged communities in Malaysia and Colombia, and we evaluated it in a cluster randomized controlled trial. And it worked far better than we ever could have imagined, working with a community to find solutions that met their needs. So that is why we have organized this session in the way that we did. We knew that we could not take you into the field in small groups to spend time with the communities. We would have loved to have done that. But what we could do was to find some of those communities where people had done really interesting things. And of course, with the magic of video, we could bring their stories to you. Even more important, we could bring some of those who are involved in making these things happen to this conference so that you can hear from them how they achieved what they did. Now, it's not for me to tell their stories. Indeed, that would be the last thing I should be doing. But I can perhaps make a few brief observations. For me, the film from Kyrgyzstan was personal. Twice in the last 2 decades, we undertook studies there, talking to people with diabetes. Indeed, we used this work to develop our concept of tracer conditions, conditions whereby understanding the lived reality of patients and frontline providers, we can identify the weaknesses in the health system. And believe me, what we have seen today is a remarkable achievement. And then we have the mental health ambassadors from Denmark, and I'm so pleased that you're able to join us today. This is absolutely inspirational. Please do talk with all of these groups and be inspired and learn from their experiences. But it's not about what I think. It's about what we can all learn from those who depend on health systems. And it is them, not me, that we all need to listen to. Thank you very much.
Thank you, Martin. I'm just going to walk over to the other side of the stage because now we come to this part of the panel. It feels like a soccer field, trolls, almost, at the end of a long day. But I'm very pleased that now we come to the second part of the panel where we can reflect on what we have heard, but I want to push a bit further. And to do this, we have Claudia Luati from the European Patients Forum. We have Karen Bureau from EFNEMA, the European Forum of National Nurses and Midwives Associations. And we have Doris Pulamets, who is the president of the Estonian Medical Students Association. And I will start with them before moving to my longtime friends and colleagues, Vesna Kirsten Petric from Slovenia, who has been a policymaker, a director general, but also has been the chair of the executive board of WHO, and Lisa Maria Wojciechowska. I can never get your surname right, Lisa Maria. She's always Lisa Maria to me. But Lisa Maria actually worked as a clinician for many years, as an internist, and really at the emergency situation, and then became chief medical officer in Finland. So I will push, we've agreed, Vesna and Lisa Maria, also to be a bit critical, because it's very nice for us to talk about co-creation. We all want co-creation, but how do we make it happen? But let me start with Claudia. Claudia, most of our patients are older people, sometimes people with the poorest health literacy, sometimes people going through very vulnerable periods in their life. Are we really expecting these people to fix our health system? Do they want to? Is it fair to ask them to do this? What's your view as European Patients Forum?
Thank you very much, Natasha, and thank you very much for having us today and for inviting EPF to participate in this very important event. I think you're playing devil's advocate here, so I will have to respond and to pick up on your question. I think, first of all, it has to do with the way that we view patients in our societies. And it's true that we have this vision of people are older as really subjects and not really active in their care. And I think really the inspirational talk that we heard this morning challenges that idea. People are willing to engage, and we need to see them as people, not only as patients. They're not just a number. They have dreams, they have aspirations, and they have a desire to get engaged in these discussions. So that's the first part. And of course, there are a number of enabling factors in order to make patient involvement and patient empowerment a reality. So first, this shift, this cultural shift in how we view patients, and also, the ability really to give them a voice. So having the mechanisms in place to capture their feedback and to make sure that they are part of the conversation. So of course, that can be done relatively easily, through forms, surveys. Digitalization also plays an important role. As I think Martin mentioned, you have new methods, new apps, new platforms in order to be able to provide that feedback. And here as well, we need to make sure that the needs of the patients are at the center, and that the digital revolution is also patient-centered, in that it provides another option really for patients to get involved. The other piece of this is really about health literacy. And really, I cannot emphasize enough how important investing in health literacy is to have to give patients the ability to provide meaningful input and to be involved, throughout their care and in this process. And at EPF, we really believe that all patients have a fundamental and legitimate right to access high-quality, objective, unbiased information about healthcare, about their care, about their treatment, about the options that are available to them. And this right information and resources are fundamental tools in order to be empowered and to participate in your own care and also broader in society. And here, and this is my last point, this also relates to the role of patient organizations. Patient organizations play a key role in developing materials, tools, in order to provide that information, and to create information sometimes with healthcare professionals that is really targeted at the needs of the patients. And in that role, I think they really need to be supported as well.
So we heard earlier in a session on mental health, Trolls saying the benefits that actually people who have a similar condition can derive from just being a group, a community together. And I think this is what you are also saying when you talk about health literacy, about patient organizations really bringing people together. So if I were to ask you, clearly in these case studies, patients are literate, they're playing an active role. Is this something that we just see sporadically in the WHO conference selected studies? Or do you have a sense of optimism that there is a wave, a movement growing, and that we are seeing more and more patients becoming actively involved with perhaps more openness from professionals that you work with and policymakers?
Yes, I think definitely there is a very important movement there. And when EPF was created 20 years ago, we started really from zero in about patient involvement, patient empowerment, and I think we've come a long way. And the fact, today that the patient voice is so important in this conference, I think is really a testament, to how far we've gone in pushing that message. But we're not there yet. Of course, there is still a lot that we need to do, in order to make
What
sure
do we need to do to make it easier for patients?
Well, I mean, I mentioned some of the things, investment in health literacy, that's really important. Investment in patient organizations, in their ability to play a role in society and to have the funding that they need, because we've seen it.
So it's building capacity. I think it's really building the capacity in the individuals and building capacity in the organizations. This is what I'm taking away from your message, and that people want to play a role, people want to get involved. Sometimes perhaps they just don't know how to. Thank you, Claudia. Let me move over to Karen. Karen, I mean, imagine that we can really empower nurses. Nurses are the largest part of our healthcare workforce. They spend most time in terms of contact hours with patients. In the 3 case studies that we saw, nurses clearly play a critical role. But is this happening enough? And perhaps if I can ask you, what do we need to get nurses to become what I like to call agents of transformation? And what are the barriers they encounter in practice? Let's get a real feel for what the situation is on the ground.
Oh, wow, what a magnificent question. Thank you so much, Natasha, for that question. Nurses across Europe are now educated with 3 to 4 years in higher education, and they are prepared for evidence-based decision-making. Many countries are also now implementing advanced roles for nurses, especially in primary health care, and many of them have master's degrees. So nurses are well prepared. But the important question is the system ready to utilize the skills and competences of nurses and midwives? Nurses want to deliver safe, compassionate care, but nurses have to earn patients' trust. And in the video from Denmark, the nurses didn't know what to say to the patients who came to the ER with self-inflicted harm. They also sutured patients without anesthesia, which wasn't very evidence-based, and it certainly wasn't compassionate care. So they learned to communicate better with these patients, and they learned that suturing without anesthesia actually harms patients. And they changed their practice. Listening to patients and reflecting on their practice was important for transformation and a prerequisite for developing trust with patients. A critical factor for transformation in nursing is leadership at all levels. In the impressive transformation of diabetes care in Kyrgyzstan, the chief nursing officer was an important agent of transformation. And we see in country after country that has established the chief nursing officer role that this advances the utilization of nurses' competence in the healthcare systems of these countries. The CNO knows the skills that nurses have and their potential to contribute to the healthcare system. The CNO is an important source of vision, inspiration, and encouragement for nurses. And this creates energy. And as we all know, energy is important for change. We often see that lack of support from the medical profession is a barrier to utilization of nurses' skills and competences. Again, the good example from Kyrgyzstan showed support from the chief endocrinologist and the medical profession facilitated the transformation of the system to change nursing practice and to utilize their competence. Nurses and doctors working together at all levels of the healthcare system is important to develop trust. This project from Kyrgyzstan shows that the government values nurses and the nursing profession, and it required investment in leadership, in education, and in regulatory changes. This is extremely important for retention of nurses in the workforce. Thank you for these excellent examples and for your question.
Thank you, Karen, for already having gone a step or two or three forward and used these case studies. This is exactly what we were hoping that they would do. I could really see how they can be used with groups of nurses to illustrate exactly these points that you have captured so very well. And I'm sure with Maggie and our team, we will be able to use this material and amplify these points that you have picked out so very nicely for us. Thank you for taking the time to do this. It's very rewarding to already see that this work can be used in this way. Doris, I come to you, the president of the Estonian Medical Students Association. First of all, thank you for your activism. Sometimes we are told that young people are not active. It can't be further from the truth. At WHO, we are benefiting very much through our Youth for Health initiative from the commitment and passion of a number of young people. And of course, we need this because the future of our health systems depends on you. But again, in an earlier session this afternoon, we heard that sometimes our health systems don't talk to young people, and what we are providing does not meet their needs. So as a future doctor, representing your colleagues, medical students, does anything in these case studies speak to you? Or are we totally off track, or are we still lagging behind and trying to catch up?
Thank you for having me here. And of course, it does speak to me. For young people especially, I believe they should be included in the mental health talks as well as HPV vaccine talks. As we, as the young people, we know how to promote, for example, the vaccinations to young people. And we can be there creating policies with you in order to get better traction from, the people. So yeah, I believe that young people have a huge role to play, and we should not limit this to only these case studies. We have already shown that during the COVID pandemic, for example, we did stand up and we did fill the gaps that were in our healthcare system in order to help out anywhere we can, within hospitals or outside For example, our organization helped out with reaching out to people regarding COVID vaccines, and we saw great results. This reduced the medical doctors' administrative workload, and in return, we got this great experience of already doing and preparing for the work that's beginning and ahead.
Thank you. And I'm sure that you are already actively engaged. But anything perhaps that you would like us to do differently in the way in which you would like to see healthcare professionals being far more engaged in driving change and transformation rather than being passive recipients of policy measures that are made, as Martin said, in a ministry, in a boardroom?
So I believe the key point is including them in the promotional work, not only having, the young person there as a face, but having them also do the work so that they're not a token, but they also get to actively participate. That's the key word here. We don't want to only be on the stage and, talk the big talk, but we want to, on the policy levels, go and do the stuff that we have promised and be the change that we always talk about.
Thank you, Doris. And I can see Vesna smiling and raring to go. And tomorrow we will have the session on youth and civil society. And I guess one of the things that I want to bring out is that it's not enough to have patient organizations and the health workforce. We need to go beyond. I don't know if you were listening carefully when Mark spoke this morning and read out Hans's speech. And in one of the paragraphs, we spoke about the need to go out to the population that is going to be voting this year in so many countries, the people. And this is always what Vesna talks about, that we can't limit ourselves just to the health sector. We need to go to communities, we need to engage with civil society. But Vesna, as someone now for many years based in the ministry, totally committed and passionate to working with young people, working with civil society, engaging them in making these transformations. How easy is it? How difficult is it? And if you have to reflect back, maybe on some time when you were successful, or some time where you were left disappointed that it didn't work, could we have your thoughts on that? I know it's a subject very close to your heart, but we're in good time.
Thank you very much, Natasha. This is a great question to me, and I really love these discussions today on trust. But to start with, I would ask the audience one question and then another one. And the first question is, do you consider public health as part of the health system? Please raise your hands. I mean, come on. Yes, you do. Great, because in 2008, first Tallinn conference, we all agreed upon, so I was worried if somebody maybe forgot about this. So now the second question, could you consider NGOs, civil society, organized citizens and professionals in their free time, not just working as nurses, but in their free time also, that share the values we have in health sectors and have the same vision and are active to contribute to better health of population, also as part of the health system? Some do, some don't.
It's
I do.
Work in progress, Vesna. There's still work
it's
for you
in progress. I do. And everything that Natasha said, like I work so much with NGOs and so on, why I do consider them part of health system is because I would do very little in my 30 years career at the Ministry of Health if it was not for NGOs, organized young people, nurses, organized nurses in their free time, not so much doctors, sorry, and some other NGOs, some other people of goodwill and wanting to contribute, also organized patients, wanting to contribute to better health and better health system in my country. Because it's not so good to have a very good functioning health system. You have first to talk to Minister of Finance, and he has to get it. And then the parliamentarians, they need to understand that they have to invest in health system. And it's not easy to persuade them. And there it was where I realized the power of organized citizens who want to contribute to better health and better health system. And that is why I'm such a believer in, that we should further invest. And when I say further invest, I'm meaning WHO. So we are now speaking, of social participation a lot, and social participation is actually about people contributing to decision-making, organized people, citizens contributing to decision-making. But we have heard today so well, it's not only about decision-making, and especially is not what you so well explained, being there just for the number, click, young people here, click, patients here. It's not about that. It's them really, us, not them, being interested in what they have to say so that our decisions will reflect much better the real needs of people. And our, measures adopted will be then really there for those people. That is why we want to have them around the table. And also, when implementing, sometimes we think we know everything. We are so, into it that we can sort everything. But look at the situation now. There's so much misinformation on social media, and us health people have difficulty. How can we deal with this? I mean, we ask nurses to help us with health literacy. But they do a lot of work already, and we have lack of nurses in my country, at least. How can they do this in addition? They can do it a little bit with the patients, but we need them to do it with the general population as well, especially young people who maybe even don't attend health centers, Okay, let's put it to the schools. Yes, fine. We'll wait 20 or 15 to 20 years to get somebody health literate out of there. And honestly speaking, schools, they don't want to have more in their curricula as they already have. They are very resistant to have additional things in their curricula. Why not ask young organized people, as a lady here, to help us peer-to-peer to contribute to health literacy of young people? And what will this serve for? A lot, because doctors in my country, especially at primary level, they say that it's very difficult now with young patients because they demand things that, actually doesn't make sense because they have got this information on social media and now they are burdening health system with all sorts of questions, and it's very difficult for health professionals to address this. They want because they know it's important, but they cannot.
But from Margaret's survey this morning, actually, we are seeing that this is where some of the loss of trust is, the educated, urban, elite, young people. And I think this point that you are making talks very much to the research that Margaret presented this morning. So, of course, Vesna, I'm still pushing for what's the hallmark of success and when do things not work out? How can we,
two things.
Think about that?
One thing is that if you really mean it, working with civil society, honestly, and if they are part of the system, you have to think of how to ensure their sustainability. It cannot be to finance them project by project or them to lean on charity funding or something like that. It's a special sector, I would say, and if we are paying, research to do the job, and we are paying health professionals to do their job, we should also make sure that civil society gets some resources, some operational funding so that they can perform, but not only that they can perform, also that their work is sustainable. It's very important, this. So we were fighting at the EU level for EU to finance or to give operational grants to networks, international networks, because it's not just important within the country, also internationally, this goodwill people, civil society, there's exchange and so on. So what is not working that well is that in my own country, public health institute people, and we have Tit here, he's somewhere here in the audience, you know, some people do, for example, Urshka there, really understand the power of, you know, people contributing and so on. But in public health institutions, still people are not aware of the fact that whatever guidelines they produce, they need to be implemented on the ground. And they don't understand that themselves cannot do all this work, but there are some people who could help them do it, and these are the NGOs. But how can they help? How can we trust them that they will do the right thing, you know? You cannot just give them the guidelines and they are running around. You have to actually invest in those entities, so NGOs, civil society, young people, if you want, patients, and you have to, professionals, we have to work with them. And there needs to be some space to do so. There needs to be our obligation. It's not yet there. Not in our public health institute, I think not in many other public health institutes yet.
I'm sure that there's still plenty of work to do in this sector, but I will repeat a point you made, which I thought was key. That sometimes, as advisors, we cannot influence politicians just by presenting them the evidence ourselves. We need to go in a roundabout way to somehow get people on board and make it the wish and desire of the people. And that's something I think that we can do far better. Thank you, Vesna. I'm sure your session tomorrow is going to be most interesting. Turning now to Lisa Maria. So you were in the hospital practicing, probably thinking, how is it that these people in the ministry make these stupid decisions? They don't talk to us, they don't know what they are doing. And then some years later, you find yourself as chief medical officer. You enter full of good intentions, and you face the reality day to day. You want to involve your professional colleagues, and yet there are difficulties. So I've asked Lisa Maria to reflect a little bit on how actually as policymakers, as ministries of health, as chief medical officers, we have other chief medical officers, colleagues in the room, can we build this bridge of really involving health professionals, of wanting them to feel that they are part of the change? And what are the practical obstacles that we all face?
Yeah. Thank you, Natasha. It's a great question and very interesting topic. Well, first, I would like to emphasize that it's absolutely necessary to involve and learn from professional expertise for evidence-informed policy making or whatever it means, as well as ex-ante impact assessment of those intended reforms. But then as a civil servant, and we are many in this room, I believe, how do you make this happen in reality? Because it's absolutely impossible to gather all the necessary professional expertise in ministries or even specialized governmental institutions or public health institutions, you name them. So I think that you bring with you yourself to the ministries your new positions, your networks, and then you need to maintain and create new networks that are able to mediate the knowledge and expertise from your health systems and academic institutions to the government. And I would like to also emphasize vice versa, to explain why the political machinery is taking steps that sometimes are not easily palatable to professional interest groups. I think we all have experience of this. So I came to think when I thought about the question that quite often it is all about us civil servants with a professional background acting as language interpreters. And it helps if you, deep in your heart, can understand why people have strong opinions, they have vested interests that make it difficult for them to accept compromises and those small steps forward, which are so often the reality in democratic decision-making processes. Then when the decisions have been made, and sometimes they are big steps and big decisions, reforms and so on, then what it takes and how can we empower our healthcare professionals to lead that transformation? Then I think that we too often talk to our peers, the chiefs here and there, but it's important to have advocacy at all levels of our health systems. And this brings me back to the issues of education, which have been discussed here earlier. The education of healthcare professionals, be it nurses, medical doctors, dentists, physiotherapists, you name it. Of course, it's important to teach the theory and practice of being a professional, but on top of that, I strongly believe that you also have to understand how, why, and for what purpose the health system exists, and how its performance can be measured and valued. And then finally, going back to the issue of these networks, I think we work in ministries and public health institutions that can be ivory towers also. It's important to invest in expert networks. Also, after a few years, when you don't know the people anymore and your own networks are all gone. So they have to be real infrastructures, permanent expert networks. They can be different in format, but they have to be established. Because trust is important, but when a bad day or big challenges do come, you benefit from existing platforms and information exchange channels between the frontline and the government. And if I may share my personal experience here, when the COVID crisis hit Finland, I hadn't been working with the intensive care units and their networks for a while, but still it was easier for me to approach them, and we had a very good cooperation, a very quick response from the intensive care units and the community in Finland, because we already knew a little bit about each other and we had a little bit of the same language to share. Thank you.
So I think if I summarize the message from Vesna and Lisa Maria, who between them, and I'm fast approaching, accumulate many, many years of experience, and you won't mind me saying so, is a reality. I think the key message that we are hearing is build alliances, build networks, and networks with people. Whether those people are professionals, whether those people are patients, whether those people are youth organizations and civil society, there is no way we are going to manage this health system transformation from within ministries of health alone. We need to become closer to the people, and the ministers in the room probably understand this very well and preach it to us very well. And sometimes those of us who are scientists are a bit resistant and hesitant to take this step. But I think this has been a clear call. We still have a few minutes left. We don't need to use them all, but I'd like to throw back to the other side of the room, to Marge, to see if any of the colleagues from the case studies have any thoughts or reflections having heard this side of the panel, so that we can close the loop.
So can I ask now our case study representatives to whether you have any reflections or thoughts that you have thought after you made your intervention and listening now the international panel, and want to respond, or something that you want to really take away from going through this process of having thought through your journey in being part of that change and something that you learned. So either or, so either you want to have reflection back to the other side of the stage, or something internal, that what kind of you take away from this process of being part of the journey of putting these cases together and analyzing them in depth. So I don't know who wants to go first. I see Urška is maybe sorry for prompting you, but
yeah. Besides being the head of the cervical cancer clinic program, I'm also leading the NGO, the oldest one working in the prevention of cancer in Slovenia. It's an association of regional societies. So that's my volunteer work. So I'm quite well into NGO activities, and we have quite well-organized NGOs in the field of cancer prevention and care in Slovenia. And I feel that when we will switch to HPV screening, prolonging the screening interval, increasing the starting age again, we will have the support. We will do it together, hand in hand. That is because we have worked together for many years. We are inviting them to join us when we are making decisions, when we are organizing events, they are inviting us. So this part is very important. However, I would also like to tell you an example what's also happening. For example, cancer screening is comprehensive. Less is sometimes more. People have to be quite health literate to understand that. And despite 20 years of organized screening with great results in 2-year intervals, I'm still every few months answering the initiatives from citizens that we should go back to 1-year interval because it's better, it's safer. So I think we should be aware that there are people out there, there are NGOs, there are people that are not organized, and we should address all of them in terms to I really think the health literacy is very important. It is very complicated, but it's important that we are aware that if people will understand that we are doing something for their good, and it's not, for example, money saving, if we go from 1 year to 3 years, then that is the moment where trust will be built. It's not just the results, not just the data, we have this, but we still have this, I would say, lack of trust, and that's why we have these requests. So I do agree with all the words said today, and I'm glad to be here. So thank you, everybody, that make that possible.
Yeah. Thank you, Urška. And also one thing that I learned from the Slovenian case study, and that it demonstrated well, is that transformation is not, there is no end. And although you have had the project for a long time, the program for a long time, then you see these challenges and you have to be vigilant and build the trust and use what you have. And so you can create the virtuous cycle along the way, but you have to understand the barriers and new challenges that are faced.
Yes, and also the trust is not just the trust, is it there or not, it's the trust among very different stakeholders, and it's like a cascade of trust. So in Slovenia, because screening is done by primary gynecologists, women trust them, so that was never a problem. Public health experts leading the screening program and Ministry of Health, Public Health Directorate, there is a trust, but there was difficult to build the trust between, I would say, clinicians and public health program. But during the years, we succeeded, and it's the same with NGOs and civil society.
Thank you. As you can see, that these case studies are really rich, and also use the opportunity for the next day to meet with these people and have conversation, because this is what we also want to facilitate. I'm coming to you, Trolls, because you mentioned that there is something key, one key thing that you forgot to mention during the case study session. Maybe you want to come back to now so that you won't forget this.
Thank you. Well, actually, I would like to start somewhere else, because what was one of the points that networking and building experience together is a very important part of start some cooperation so we can move forward on this different initiatives. When it comes to stigma, I believe that we have a big organization where many of these, like One of Us organizations, kind of transfer their experience. They have conversation and trade experiences from their country and kind of inspiring each other. And I think that is a very important goal in combating stigma, is to, well, you're not alone in this area in your country. You are part of something greater, but we just have to kind of make this cooperation between the organizations more international.
Thank you, Trolls. And Natalia, would you also want to say a few words to reflect back what you heard, or add something that it's really pressing on your mind that you want to use the opportunity to tell everyone?
So I think we are moving in the correct direction, that we see similar problems in other countries. The only thing is funding of our medical system, health system. And considering these lessons learned, we are going to increase this work with patients, feedback from patients. I liked the idea about patient-based organizations like youth and senior people. And we do have surveying, but we would like to consolidate this monitoring. And I like the phrase, you go slowly, but don't stop. And we will try not to stop.
Thank you. So I think a round of applause for our panelists. It's been a big panel, an interesting and rich panel, and they've also ended ahead of time. We will need 5 minutes to change the stage very quickly to prepare for the signing of the outcome statement. So I can kindly ask the panelists now to return back, because we will need to move the stage. And thank you so much. Thank you.
Thank you.
And in the meantime, because I'm taught never to waste a minute, I've been told that to fill the time until they move the chairs and do everything else, I will make some important announcements for this evening, so we don't keep you longer then and later. So, first and foremost, there is a reception this evening at 19:30 hours, with pickup from both hotels at 19 hours, 7 p.m. All participants, I am reading, are invited and encouraged to attend. We look forward to seeing you. There will be the bus transfer from the Nordic Forum Hotel to the venue tomorrow morning at 8 and 8:15. And tomorrow there will be 2 bus transfers from the meeting venue to the airport at 15:30 and 17:00. And what we will do also is we will put all of this information either in an email or in the app in case you forget and you want to look for it later. So I think the most important thing for tonight is buses for the reception leave at 7 p.m. and you are very welcome, and we look forward to seeing as many of you as possible. And of course, we have done our bit to try and make sure that we end on time, to give you some time at least between getting ready to attend the reception. So they told me I had to fill about 2 to 3 minutes. I'm not sure whether we're done. Clayton, are we done? We're good to go. Very good. So we can move on to the next now.